now we can move for second speaker for today, and he is well-known figure in Mega Academy, also in Saudi Arabia, also in our community for anesthesia personnel. So the speaker, personally, I like to learn from him, as he used all the time a very interesting subject, at least to me and for some of our colleagues. His Dr. Mohamed Ahmed, his credential master degree in anesthesia 1993, MD in anesthesia 1999, Alexandria University. It was about cardiac surgery or cardiac anesthesia for cardiac surgery. And he's former associate professor of anesthesia in Alexandria University. Now he's a consultant for anesthesia at King Fahd Specialist Hospital in Dammam, Saudi Arabia. Today he will share with us a very interesting topic, at least for me, for patient safety and also physician safety. The consent. What is the consent? Why we need a consent? What is the informed consent? Quality of consent, and many other questions to be answered about consent in his presentation. Ladies and gentlemen, please join me in welcoming home Dr. Mohamed Ahmed. The presentation is yours. Excited to listen from you or to hear from you, Dr. Mohamed. Let's go.
Thank you, Dr. Yasser, for this nice introduction. I would like to thank Dr. Fahd and Dr. Irfan, and of course, I would like to thank Dr. Fahd for his very nice presentation that we all enjoyed. Today, my topic is a little bit different because we will not discuss a clinical case or a clinical scenario. We'll discuss an issue that we are practicing with every patient. It is the informed consent. And in this topic, we will go through a brief introduction discussing the definition of the informed consent, and then we will answer the question why we need the informed consent and what are the situations that we have to get informed consent from the patient. And then we will discuss the conditions that make the informed consent valid and sound. And then we will review the quality of our informed consent. First of all, the definition of the informed consent as it was defined in New England Journal of Medicine in 2007, it was defined as the process by which treating healthcare provider discloses the appropriate information to a competent patient so that the patient may make a voluntary choice to accept or to refuse the treatment. So in the process of the informed consent, we have two parties. The first one is the patient. Patient has the absolute right to decide what will be done for him. But in order to take the proper decision, he must know. And the information is deficient at the side of the patient. So the duty of the physician who is treating this patient is to supply and to offer the patient with the information about the disease and about the intervention that will be done to that patient in order to enable the patient to take the proper decision, either to accept or to refuse the treatment offered by the physician. Why we need informed consent? Informed consent is needed because law enforces us to get informed consent from the patient before any intervention. Medical ethics also requires the informed consent from the patient. The healthcare practice standards necessitate the informed consent of the patient. Also, the culture and religion need the informed consent. I will start with the religious background of the informed consent. If you will come to work in Saudi Arabia, you will find that the informed consent is very important. When you ask them to call the patient to come to OR from his work, nurses will never shift the patient from his bed to be transferred to the to the OR except if the informed consent is taken properly and the process is complete. And when you know that the law in Saudi Arabia is the Sharia law, you may ask what is the relationship between Sharia and religion and the informed consent. And when you look for that question, you will find this hadith, which was narrated in one of the most sound and authenticated books of hadith, which is Sahih Muslim. In this hadith, the wife of the Prophet Muhammad, peace be upon him, says that during the sickness and during the disease of the Prophet in his last days, they tried to give the Prophet some medicine, but the Prophet refused and he didn't get that medicine. And then they thought that this may be the natural dislike of any patient to the medicine because the medicine may be of bad taste or bad smell. So usually the patient doesn't want to take this medicine. And they waited until the Prophet went into something like fainting or some loss of consciousness, and they poured the medicine inside the mouth of the Prophet. When the Prophet, peace be upon him, woke up, he found the taste of that medicine in his Prophet, and he disapproved what they did. And the scholars of Sharia concluded from this hadith that it is the absolute right of the patient to accept to be treated or even not to be treated from the disease. And we can also conclude that if the patient, during his full capacity, he is fully conscious, this patient refused some medicine, we don't have to give him that medicine or that intervention that he refused when he lost the consciousness. This is what is known in the Western countries now as advanced directives. Some people, while they are fully capable, while they are fully conscious, they write their advanced directives. They write their wishes in advance. They say that if I will be comatose due to head trauma, due to Alzheimer's, due to any reason, please don't put me on mechanical ventilation or don't put me on hemodialysis machine. And these directives are very respected in the Western countries, and they cannot do something that is against the wishes of the patient while he was fully capable. Not only in the Islamic Sharia, but if you will look in the Bible, you will find also in Gospel of Matthew chapter 21 a story between Prophet Jesus, peace be upon him, and two blind patients. These two blind patients called the Prophet Jesus to cure them. And before he was curing any patient, he was asking him one question: what do you want me to do? And then he will do what the patient needs. He is working in the best interest of the patient. They asked him to cure him from to cure them from blindness, and they did what they asked. So we have to work according to the best interest of the patient, not according to the best interest of the physician. Also, good examples that show us how the religious beliefs affect the process of the informed consent and the maneuvers that has to be done to the patient is the Jehovah's Witness. If you are working in a country and you will in a Western country and you will meet one of these Jehovah's Witness, these are a religious group who believe that blood is life, and life is only under the control of God. And on that basis, they refuse any blood transfusion. So you have to work according to their best interest, and you have to avoid any blood transfusion for these patients. And they accept and they prefer to die even if they will not be transfused with blood. It is better for them to die than to be transfused. Law enforces the informed consent. And the first court statement about the informed consent was in New York since more than 100 years. when a lady went to a gynecologist and he examined her and he suspected that she has a tumor in her uterus. And he recommended to do examination under anesthesia, and the lady approved to be examined under anesthesia. And when the physician examined the patient under anesthesia, he discovered that this patient has a malignant tumor in her uterus, and he proceeded to do hysterectomy. When the patient woke up, she found that her uterus was lost during anesthesia, and the patient didn't approve of that while she was awake. So this patient sued the gynecologist before the court, and the court ruled against this gynecologist, and the famous statement of that court, it was, every human being of adult years and sound mind has a right to determine what shall be done with his own body. If you are working in UK, you have to read this article that was published by the Association of Anesthesiologists in Great Britain and Ireland into 2017 about consent in anesthesia. And you will find that if, according to the law in UK, if you will touch or needle a patient without previous consent, you are liable to be charged as a claim of assault or battery. And if any complications happen due to your intervention as no consent was taken from the patient, this is a claim of negligence, according to the law in UK. In Saudi Arabia also, if you will do any intervention to a patient without consenting him, and the patient develops any complication without any discussion, you will be blamed, and you may need to compensate that patient about any loss or any complication happened for him. In 2015, the Saudi Commission for Health Specialists, this is something like GMC in UK, issued a handbook for the resident about professionalism and ethics. And it mentioned in that book that consent will protect the physician, but it is, of course, it is not complete protection. But if you consented a patient and you did your job properly, you will not be blamed if any complication happened, as this complication is a recorded complication and non-complication of that procedure. But if no consent is taken from the patient, you will be blamed from the start without even investigation. A very hard and difficult situation that anyone may face, alhamdulillah, it is rare, thanks that it is rare to face this situation. If you have a pregnant lady, full-term lady, and this lady examined by the obstetrician, and the obstetrician decided that she has to do emergency CS now to save the life of the baby. But the lady refused to do CS. And the obstetrician said that if we will not do CS now, the baby will die. What will be the situation? Can we give her anesthesia against her will to save the life of the baby? According to the law in UK, no. Absolutely no. The patient has the right to refuse to do CS to save the life of her baby. In Egypt also, in the Code of Ethics, which was issued by the Ministry of Health in 2023, it was mentioned that it is forbidden to do any intervention to any patient without the informed consent. So according to the law in all countries, you have to get informed consent from the patient before any intervention. According to the medical ethics, we have also to get informed consent from the patient. We know that medical ethics have 4 pillars. The first pillar is autonomy, and autonomy means the absolute right of the patient to determine what will be done in his body. And under the autonomy, we have the informed consent. We have the respect of the privacy of the patient and respect of the confidentiality of the patient. The second pillar is the beneficence, that we have to do what is beneficial for the patient, what is good for the patient. And the third pillar is non-maleficence, which means that we have to do no bad thing to the patient. And the fourth pillar is justice. We have to treat all patients in the treatment according to their gender, according to their color, their religion, their position in the community. We have to treat all patients equally. Sometimes we practice some attitude which is not accepted. This is the attitude of paternalism. The physician will deal with the patient as if the patient is his young kid. He thinks that his young kid doesn't know what is good, what is bad, what's beneficial, what's harmful for him. So the dad will choose for the young kid and will decide for the young kid. So he is dealing with the physician as if the physician is a young kid. And this is not accepted in the modern healthcare practice, and it does not protect the physician if the patient will complain. So you have to inform the patient, and you have to leave the decision of treatment and the choice to the patient, not to choose instead of the patient. Someone may ask if autonomy means the patient has to decide, and beneficence means that we have to do what is good for the patient, and non-maleficence means that we have to do no bad for the patient. There is contradiction between autonomy and beneficence. As long as autonomy gives the right to the patient to decide, and the patient may decide something which is not beneficial for him. Why I will prefer autonomy over beneficence? I will not prefer. My duty is only to inform the patient with the knowledge that enables him to decide. And then the patient will decide, and the patient will choose the modality of treatment that suits him, that from his point of view, it is more beneficial for him than the other. If you are working in a healthcare facility which is working according to the advanced and recent standards of healthcare, like in Saudi Arabia, many of the hospitals are seeking to be accredited by the JCI, Joint Commission International, which is a USA commission for accrediting hospitals. So you will find that according to the healthcare standards, there are two types of consent. There is general consent and there is informed consent. General consent is the consent that is signed by the patient upon admission to the hospital, or when the patient comes to the hospital for the first time. In this general consent, patient will accept to be treated in that hospital. Patient will accept to be examined by the physicians of that hospital. Patient accepts to be for any minor intervention like intramuscular, intravenous injection, like blood sampling for laboratory, like chest X-ray, like IV fluid infusion. All these minor interventions can be covered under the general consent. But there is another more important type of consent, which is informed consent. Informed consent, according to the healthcare practice standards, it is a consent that is taken from the patient before a specific interventions. And each hospital has to have a list of the procedures that need that informed consent. All agree that informed consent is needed before every anesthesia. All agree that informed consent is needed before any procedural sedation and any surgical intervention and any blood transfusion. Before any of these procedures, we have to have informed consent from the patient. Now, what are the conditions that are needed for the informed consent to be valid and solid? We have three conditions that has to be available in any informed consent. Informed consent has to be voluntary, has to be informed as its name denotes, and has to come from a person who has the full capacity to decide. The first condition, voluntary, means that we don't have to press or to force the patient to accept or to refuse a modality of treatment. If you think that spinal anesthesia is more favorable for you as regards the benefit of the patient, you have to explain to the patient and offer the patient with information that can convince the patient that spinal anesthesia is better for him. But don't press and don't force the patient to receive spinal anesthesia against his will. And also, we don't have to give the patient any privilege to accept one modality of treatment over the other. And the example of giving patient any privilege, those who wants to include the patient in their research. Sometimes, if you want to encourage the patient to be in your research, you may tell the patient that you can reduce the fees of the cost of treatment by 10%, or you can add 1 day for hospital stay, extra day hospital stay for free for the patient to encourage him to be a part of your research. This is ethically not accepted. The second condition that is needed for the informed consent to be valid is the consent must be informed. What this means, informed means that the patient has to decide after we supply the patient with the information and the knowledge that enables him to decide. So we have to tell the patient we have to talk the patient about the diagnosis of the disease. We have to talk with the patient about the modalities of therapy. We have to talk with the patient about the prognosis. If he didn't receive any treatment for that, we have to talk with the patient about the benefits and about the risks associated with each modality of treatment. How much information is enough for the patients to decide? Of course, we will not inform the patient as if we are explaining the disease and its management for a medical student. Patient doesn't want to know all this knowledge about the disease and its management, but he has to know the information that enables him to take the proper decision. And if you will ask this question, how much of the information is considered enough to make the patient to make his mind and to decide? If you will ask this question for the experts, you will find subjective answers like this answer, which is it is according to the reasonable practitioner standard and according to the reasonable patient standard. So the word reasonable itself differs from one to another. If I think that this is reasonable one, another one may think that this is not reasonable enough. So if you will give a patient spinal anesthesia, do you have to inform every patient before every spinal anesthesia that there is a possibility of spinal hematoma after spinal anesthesia, and that the patient may develop the paralysis of the lower limbs after spinal anesthesia? Although you know that the incidence of spinal hematoma after epidural is 1 per every 3,600 cases, and after spinal intrathecal is 1 per every 18,000 cases. Do we have to tell the patient the possibility of spinal hematoma? For every patient will go for spinal anesthesia. Do we have to talk with the patient about the possibility of developing anaphylaxis due to any of the drugs used during the management of the patient inside the OR? Although we know that the incidence of anaphylaxis, perioperative anaphylaxis, according to the NAP60 study, is 1 per every 10,000 cases. Do we have to talk with the patient about malignant hyperthermia and its threatening effect on the life of the patient if it will happen? Although that we know its incidence is 1 per 100,000. Do we have to talk with the patient about this catastrophic outcomes, although it is very, very rare? in 2011, this article was published. It was the answer of this question from one of the malpractice advisors working in USA. According to this expert man, he said that he thinks or he believes that if you are expecting a complication and this complication is a major complication, will happen in an incidence of 1% or more, you have to tell the patient about it before the intervention. And the minor complications, if it has an incidence of 3% or more, you have to inform the patient about it. Study was published in Oman Medical Journal in 2011. They surveyed two groups of surgeons. One group is working in UK and the other group is working in Saudi Arabia, and they asked them about this question. And the answer of both groups, they agreed that if we expect a major complication of an incidence of 1% or more, we have to inform the patient about. And for minor complications, if the expected incidence is 5% or more, we have to talk with the patient about it. But the most important answer, specifically in Saudi Arabia, is that that answer that came in the Guide of Consent, published in 2019 by the Ministry of Health. And they answered this question: it is mandatory to inform any patient about a major complication if its expected incidence is 1%, and for any minor complication if it is expected to happen in an incidence of 5%. Why it is very important, especially for those who are working in Saudi Arabia, because the Ministry of Health is the highest governmental authority taking care of the health services all over the country. So suppose that unfortunately a patient developed spinal hematoma after spinal anesthesia, and the patient complained to the anesthesiologist. And in his complaint, he said that if the anesthesiologist discussed the possibility of spinal hematoma after spinal anesthesia, the patient might refuse spinal and choose general anesthesia instead. How can we defend ourselves? We can use this document published by the Ministry of Health as a reference for us. We can defend us as according to the guidelines published by the Ministry of Health. We don't have to inform the patient about grave complications if it is rare and if it is less than 1% incidence. Also in this guide, they mentioned that if the patient refused the treatment, you don't have to do pressure on the patient. Your job is only to confirm that the patient understood the knowledge that you are giving to him about the procedure, and you have to document that in the file of the patient. How we know the incidence, expected incidence of complications from this procedure? This is a very good way to know. It is a risk scoring. It is the surgical risk calculator published by the American College of Surgeons. And in this program, you will enter the procedure that will be done to the patient, and then you will choose the risk factors available in that patient, and that program will calculate, and it will give you the expected incidence of complications and bad outcomes that may happen to that specific patient if he will do that specific surgery. But we have to know that this was designed to USA, and of course, risk management differ from one country to another country, but it can be used as rough guidelines for us to calculate the risk of the serious complications that can happen to that patient. Some of the doctors will be reluctant to explain the bad outcomes that are expected to happen due to the intervention because they feel some sympathy with the patient. Patient may be scared, and if the patient is scared, he may refuse the treatment, but this is not the right way, and this is not accepted. What is the benefits and what is the risks to prepare himself for the risks associated with the intervention? And also, this will not protect the physician if the patient will complain. We are required to also discuss with the patient what are the consequences of no treatment, because there is a famous claim in USA when a lady went to the physician and he recommended her to do pap smear. And as we know that pap smear is a test that detects early cancer cervix, and the patient refused, and then the patient got cancer cervix, and then the patient died from cancer cervix. And their kids sued that physician because they said he didn't explain the consequences of not doing this pap smear. And in the court, the physician failed to document that and to prove that he explained the consequences to the patient, and the court ruled against that physician. So it is wise to explain to the patient the consequences of refusing the treatment. We have to be very cautious when we are delivering bad news to the patient. We have to show sympathy with the patient. We have to absorb the response of the patient. And also, we can give the patient some materials to read to know about the disease and the modalities of therapy. And it's better to recommend some websites, because some patients will Google and they will go into non-trusted websites, and they will get a very thick knowledge about the disease, and they will may take a wrong decision. So it is better to recommend some trusted website for the patient to read from it, and then you have to document all this in the medical record of the patient. Sometimes you are dealing with special types of patients. Like if you are treating a very famous singer or very famous broadcaster, and you have to do a psychodectomy for this famous singer or broadcaster, and there is a very rare and remote possibility that you may injure the recurrent pharyngeal nerve or the voice of the patient. The quality of the voice may be changed, and as we know, the voice for such kind of patient is their life, is their profession, is their source of fame, is their source of wealth. So any change of the quality of the voice of such patients is very catastrophic for them. So we have, in that case, we have to mention for them the possibility of that remote possibility of that outcome, but they have to know it. And the more common example for such situation is if you will do hand surgery or hand procedure for a patient who is depending on his hand skills for his work. In this situation, we have to discuss with the patient in details the consequences of the procedure on his hand skills. If the patient will regain his hand skills after the surgery completely or not, if the patient will be absent from his work for how many days, weeks, or months, all this has to be discussed and explained to the patient and has to be documented, because for that such type of patient, it is very important for him to know this knowledge and to decide according to this knowledge. Sometimes you will face a situation when an old man or old woman and their kids will come to you and they ask you, please don't tell our dad or our mom about that outcome, because we don't want her to be scary, and we will decide instead of her, and we will sign any paper. So this is forbidden, and this is not accepted. You have to discuss with the patient, and the patient is the only one who has the right to decide. And this is not protected for the physician. There are a few exceptions in which you can hide some of the knowledge from the patient. Like if the patient came to you and he told you, doctor, I know that there are bad outcomes and some major risk can happen due to the disease or due to the procedure that I will go through. But please don't tell me any bad news. And I know that there are some bad outcomes, but I don't want to know about this. In this situation, you have to respect the patient wish, and you have to document in the consent that the patient refused, although he knows that there are some bad outcomes that may happen, but the patient refused to know anything about that bad outcome, and patient will sign this informed consent. In another very rare situation, you may face a very fragile person who is doesn't want to know anything about his any bad thing about his health, and if you will inform him, he may get very serious events like cardiac arrest, for example, or like MI. Of course, we may not face such type of very fragile patients, except maybe once of our career in our career. But if this is the situation, you have to document this in the file, and you have to discuss with the family of the patient that you are hiding this information from the patient because of his fragile personality. And in case of emergency, if you have to go for a life-saving procedure and patient is comatose from car accident or anything else, and nobody of his family, and the operation has to be done immediately, you can go to save the life of the patient or to save any organ of the patient without informed consent. This is the GMC warning us from the situation that we talked about. Don't obey the family members if they ask you to hide some information from the patient and they will approve the procedure instead of the patient. Don't do that. The third condition that will make the consent valid is the capacity of the patient. And by capacity, we mean that the patient has the mental ability that enables him to decide. And we consider all adult patients are capable, except if we will discover that these patients have an impaired capacity. How to assess the capacity of the patient? During the visit of the patient, you will discuss with the patient and you will talk with the patient about his disease and the prognosis, and you will talk with him about the modalities of therapy and the advantage and disadvantage of each type of therapy. And then the patient will retain this knowledge and the patient will think and make his mind, and then he will start to communicate with you and he will ask you relevant questions about the disease. And if this will be the case in that sequence, this means that the patient has full capacity. So we can go with the patient to sign the consent. Who is the one who is able to assess the capacity? The treating physician, the anesthesiologist during the process of informed consent. No need to consult a psychiatrist or psychologist to assess the capacity of the patient, as long as you didn't suspect that the capacity of the patient is impaired. These are examples of diseases that will impair the capacity of the patient, like schizophrenia, like Alzheimer's, mental retardation, if the patient is dependent or under the effect of drugs or alcohol. The age of capacity differs from one country to another country. In Saudi Arabia, it is 18 years. In UK, it is 18 years. But according to the GMC in UK, you have to share the child under 18 years with the information that you will share it to his parents. If you feel that the child can discriminate and he can choose what is beneficial and what is harmful, know what is good, what is bad. You can explain to the child also, because this will facilitate the treatment and will facilitate dealing with this child if he knows what will be done for him. In Saudi Arabia, according to the guide of the consent published by the Minister of Health, from age 18, patient will be the one who signs the consent, either male or female. Nobody will sign instead of the patient. And if the child is less than 18, between 15 and 18, the child has to sign with his parents. So it is not enough for the parents to sign if the child is from 15 to 18 years, but also the child has to sign the consent, and you have to inform the child as well as his parents. This situation was mentioned in the handbook for residents published by the Saudi Commission for Health Specialists. If you will face this situation, you have a child under the age of capacity, and this child needs an immediate life-saving procedure. Like if the child came in RTA and has internal hemorrhage, and you have to go for laparotomy for that child, but both parents refused. What will be the situation? The situation, according to that book, you have to go for laparotomy against the will of the parents, because parents has no right to kill the child. And if one of the parents approve and the other one will refuse, you can get the consent from the one who approves the situation. But if the child, if the procedure is not needed now and it can be delayed for 1 or 2 days, you can wait for the courts to solve this problem. According to the law in Saudi Arabia, and everyone working in any country has to know the law there. According to the law in Saudi Arabia, if you have a child, the one who will sign the consent instead of him will be the father, followed by, if the father is not available, followed by the paternal grandfather, the father of the father, and the mother will come after the paternal grandfather. If the father is not available, the grandfather is not available, the mother will be the one to sign and to approve the procedure. Also, according to the regulations in Saudi Arabia, the consent is valid for only 30 days. If you didn't do the procedure after, say, during that 30 days, the witness is necessary also for the consent, and usually the witness is one of the nurses or any healthcare worker in the hospital, and they witness only the signature that you are the one who signed, and the patient was the one who signed in front of her, and she has to know the ID of the patient and compare it to the patient, and she has to confirm that the patient was above the age of capacity when he signed the consent. The last part of our lecture is about the quality of the informed consent. Some studies published that examine the quality of informed consent in our area in Saudi Arabia, and that one was published in International Journal of General Medicine in 2012, and they found that still the quality of the consent is poor. Regarding that, the defects in our culture are that our patient doesn't know their rights, and also many of our doctors doesn't know the patient rights well. And doctors usually do not give the patient a space or a time to think and then to decide. They usually want to get the approval of the patient in the same setting. And I think the situation is better now than the previous 8 or 10 years. This is another study that they examine the major medical ethical challenges facing the public and the healthcare provider in Saudi Arabia, and it was published in Journal of Family and Community Medicine in 2012. And number one ethical challenge was the patient right. As we said, patient doesn't know the rights and doctors doesn't know the patient's rights. And the consent came in, was ranked as number 7. Because most of the patients will sign the consent as a routine paper. They do not write, they do not read, they do not realize what is written in the consent. And some of the physician will feel happy that the patient didn't read and don't know what is written, but he signed because I wrote all the communications that I want to write in the consent, and the patient signed. It is not my job that the patient didn't read. And of course, this is unethical and unaccepted and not protected for the physician, because the job of the physician is to inform the patient by all means and to confirm that the patient got the knowledge that enabled him to decide. We don't have to criticize ourselves too much, because according to that study, which was published this year, 2020, in British Medical Journal, they examined the quality of informed consent in 25 hospitals in USA. And according to that study, they found a lot of defects in the quality of the informed consent in USA. Most of the consent didn't describe the procedure, because the patient will not know what is meant by herniorrhaphy. But we have to describe the procedure in a simple language, easy for the patient to understand. And also, most of the consents didn't mention the benefits of the procedure. And when they mentioned the risk, they didn't mention the incidence of the risk. For we are expecting that this patient may get a heart attack in 1% or in 20% or in 100% or 50%. So the incidence is very important for the patient to make his mind and to choose. So all over the world, we need to improve the quality of our informed consent. At the end, the take-home message is that for the patient, it is the patient's right to determine what will be done for him. Nobody can decide instead of the patient, neither his family nor the physician. When we have competent patients, we have to get the consent from the patient, not from his wife, his father, her husband. The only one who has the right to sign the consent is the competent patient. And for the physician, we have to know that the paternalism is no longer accepted in the modern healthcare practice, and it doesn't work in front of the court and doesn't protect the physician, and it doesn't go with the best interest of the patient. And also, we have to inform the patient with the knowledge that enables him to decide, and we don't have to hide serious or bad news about the procedure that will be done from the patient, because we think that patient will be scared and he will refuse the procedure. This is not an excuse, and it doesn't allow you to hide some of the information from the patient. Thank you.
Thank you very much, Dr. Mohamed. But we have many questions really, because it's very interesting. And the first question from me, just I want to need, and because this is the same area. For me, some patients just don't get a consent from proper assessment for regional anesthesia. And when he come to recovery, I found this is a mandatory for him because he's obese patient or can't tolerate narcotics. And I think verbal consent, is this right or wrong?
Verbal consent is accepted, but it is better for any anesthesia to be given that we to have an informed written consent, because this is more protected for the patient. We have two types of consent. We have the explicit and implicit consent. If the patient came to you to examine him, this is a type of implicit consent. He must not say that I accept that you examine me. Just that the patient came to you, he can. This is a type of consent, and it can be considered even in front of the legal areas. So verbal consent is accepted, but the more documentary is the written informal consent.
Yeah. Second thing about, can I refuse to treat the patient if he asks for a very difficult option and I will be a taxes, a very big taxes for mortality and morbidity? Can I refuse?
Yeah, it is your right. Yeah,
An
it
elective
is
base.
your right if if it is an elective. But in emergency life saving, we cannot refuse to treat the patient. But if the patient will ask for a procedure that you feel that it doesn't go with the benefits of the patient, you can refuse to do it.
Third thing is about a joke happened to me, as you said, about simple word. One day I was discussing the patient about perineuraphy. She's an English teacher. She asked me, I'm just coming for a operation in genitalia. Why just you wanted to suture my brain? It's perineuraphy, thinking like this. So I have more question for our colleague here. Dr. Burhan, he said, can a schizophrenic patient give a consent for surgery for minor for his children, a patient with schizophrenia?
Yeah, if he is stable, because schizophrenia patient will go into attacks of the disease and relapses. And if the patient is not in an attack of the disease and he can communicate with you and you feel that he has a full capacity, okay, he can give the consent. And if you suspect, you have to consult a psychologist or psychiatrist.
Thank you. Our colleague also Talat Al-Abd asking, he said sometimes we are confronted with surgical complications that necessitate removal of an organs, like a uterus during cesarean section intraoperatively. And this is a situation when just bleeding happen. And no relative are around to take a consent. What's the common legal pathway to avoid claims as the physician?
Yeah, according to all the standards, if you have to do life-saving procedure and there is no situation for the consent, you have to do this life-saving only to document that in the medical records. And to be more protective, if the obstetrician or gynecologist can consult another obstetrician or gynecologist and both decide together, it would be more protective for all the team. But for life saving, the patient has no capacity, we have to go for the procedure without consent.
Yes, thank you. Dr. Sam Higazi really have two questions. He said we have a consent that it was prepared by Ministry of Health, that is normal consent. Usually it is a normal consent, but not included anesthesia high risk. So we did it as a handwriting. Is this acceptable or not?
Yeah, it is acceptable because no consent will fulfill all the complications that may happen. And if you will find no consent that mentions the possibility of difficult airway. So if you will go with a patient with expected difficult airway, you need to write by your hand this possibility and the consequences of management of difficult airway.
Again, Dr. Assam Higazi asking another question about the patient in ICU, and sometimes he refuses intubation except during arrest only. So can we get a consent from his relative at that time?
No. If the patient has full capacity and he is refusing certain kind of treatment, we don't have to it is not the right of the relatives to sign instead of him if he has the full capacity. If the patient is not under sedation, if the patient is the level of consciousness is not disturbed, so we cannot do anything against the will of the patient.
Yeah, Doctor, our colleague, one of our colleagues asking a question I don't understand really, but the question, what is about the informed consent if the patient is in the prisons or the prisoner? You have a special request about that or?
No, he has to go as other patients. As we said, we have to treat all patients equally. So he has the right to decide if he accepts or refuse the treatment.
Dr. Mohamed Salim asking a question about if you have arrived a patient, for example, RTE, and coming to the patient comatose, and there is some situation endangering his life, and no relative to the hospital, and need an urgent surgery. How we can proceed with the consent?
We will proceed without consent. In life saving, if there is no patient has no capacity, and if there is no one of the relatives, we will proceed without consent. If you can get consent over the phone, this will not delay the surgery and will not affect the prognosis, it is okay. But if it is not possible, we will proceed without the consent.
It's okay. Another question from our colleague Hilal. He said, in proper assessment risk of anesthesia, usually discuss many things, but never discuss this. Is this right to explain or not, if the patient high risk?
Yeah, to explain, I didn't got what he... I didn't understand the question.
No, that we don't speak about risk of death in some surgery, difficult surgery. Is this right to explain the patient or not?
It is the right of the patient to know everything about the risks. So we have not asked, we will not discuss as anesthesiologist the risks of surgery. We will discuss with him the risks of anesthesia. But the surgeon has to discuss with him the risks of surgery, and the consent of anesthesia is separate from the consent of surgery. It is not one consent, it is two consents.
Yeah. And I think it's another, second question come to ask about this issue. If the surgeon take a high risk consent, is this covers the anesthesia also or not?
He take high risk consent because if he took the high risk consent from the surgical point of view, because the patient may suffer surgical complications, it will not cover us. But if the patient is high risk for us, patient has a lot of comorbidities, and he took the high risk consent because these comorbidities, it can cover.
Thank you. Really, it is a very big room for question for you, Dr. Mohamed, and sorry for that. Another question from Dr. Isam Mohamed. He said, asking about, can we take a consent by phone from a father of a child?
Yeah, if in situation of emergency, we can take the consent by phone. And the phone consent has the same rules as the phone order of the drugs. It has to be witnessed by the nurse, and we have to repeat the procedure that we need to be to get the consent about, and we have to make the speaker on for the nurse which is witnessing to hear with us.
Dr. Mohamed, please. Although I am working in a university hospital in Saudi Arabia, King Saud University, and we have already anesthesia clinic, and we are evaluating the patients before going to the theater by some days or some weeks or one day before, according to the situation. And we still referring to the medicine department, like to do cardiac referral, cardiology referral, or something like this, endocrine and something like this. And most of the time we are facing a problem with the evaluation of the cardiologist, specifically the cardiologist. They are evaluating the patient, and most of the time they are writing according to their views, away from the surgical procedure and the exposure to the anesthesia, that the patient has mild to moderate risk. I am working in Saudi Arabia since 20 years, and I didn't see more than 10 cases they are writing high risk consent. So, as you know, as the anesthetist and the surgical maneuver, vascular surgery, cardiac surgery, they are writing very mild or moderate risk, no need for ICU, no need for more investigation. And we are facing this problem. What are we going to do as anesthesiologists to face this problem? If we depend on this consent, is it right? Or to do our own consent, and how to get the right to do our own consent? This is a regular and continuous problem facing us in the university.
Yeah, we can use the opinion of the cardiologist as a guide, but it is not mandatory to follow it because we have scores to evaluate the risk, like the revised cardiac risk index. So if the score says that this patient is high risk for perioperative major cardiac events, and the cardiologist said that this patient is mild risk, we will believe the score, not the cardiologist, and we can convince the patient that he is high risk according to that score with that criteria. And we can prepare ourselves to prepare post-operative ICU or high dependency unit according to what we see, because the opinion of cardiologists can be used as to assist us, but it is not mandatory to follow it.
I mean,
and this is a, yeah.
Do we have the right in the clinic to, for example, to do ECG, and if we have experience to make echo, and to evaluate by ourselves the patient?
If we have, this will differ from hospital to hospital according to the regulation in that hospital. You know, as of course, you know, now there is a very operative specialty, very operative care. Those, it is considered a subspecialty maybe from anesthesia, and those who are specialized in the perioperative care, they can control the blood sugar of the patient. They can assess the patient perioperatively from the cardiac point of view. They can do transthoracic and even transesophageal echo. If we have these facilities, if we have people who are specialized in the perioperative care, we may not need to send the patient to cardiologist. But if we don't have, we have to consult them to assess the cardiac condition of the patient, because of course you know that we sometimes we are facing some people have a lot of hidden cardiac problems, but it is not manifested because most of them are bedridden. They do not do any activity, so they do not do any effort that initiate chest pain. And when we investigate, we find a high risk problems in those patients. And the consent, there is no consent prepared by the cardiologist for the operation. The consent of the operation is one for the anesthesia and one for the surgeon, but cardiologist has no role in the preparing of the consent for surgery or anesthesia.
There's a lot of question really, Dr. Mohammed. Another question from our colleague Hani Abdul Jalil. He said, if the patient have a full capacity to decide and he refusing anesthesia for life-saving procedure like a rupture aortic aneurysm, what is the best way to protect us and to protect the patient?
We have to confirm that the patient understood the risks associated with this, and patient has to sign refusal consent. And it is better to have witness from colleagues and to use or to seek the help of your colleague to try to convince the patient, because this will give the consent more power. If more than one consultant or more than one physician try to convince the patient and the patient refuse, at the end the patient will sign the refusal consent.
Thank you. Our colleague Mohamed Moqbil asked about, he don't understand what is the high risk consent. It may be in some area, he don't understand what is high risk consent.
Usually this expression, we are using it when the patient we are expecting that the patient may face a lot of bad outcomes, major risks after the surgery or intraoperative. We use this expression. But for me, in our hospital, we don't have a consent that is titled as high risk consent. It is in the same consent that we add the risks that are expected. If the patient has a risk to die or to get MI or to be ventilated post-operatively, we add this risk, expected risk, to the consent of anesthesia. But we don't have specific high-risk consent.
Yes. Thank you, Dr. Mohammed. Another question from Shahid Hafiz from Pakistan. He asked about how can we get a consent from incompetent or incapacitated patient?
The incompetent patient cannot approve for the operation. And we have to seek the consent from his father or his mother, the guardian, according to the law of that country.
We have a colleague, I think Dr. Mohammed Suleiman from Qatar. He's our colleague here, a consultant. He asking two questions. When a lady coming with agonizing labor pain and there is a need for anesthesia, do you think that she can understand what is mentioned as a regard the details on types, benefit, and risk, and how can we manage such case?
Of course, this will depend on the antenatal care. If the patient is prepared well in the antenatal care, she came ready for you, and she can accept and understand what you will tell about. And in that situation, if the patient is not able to decide, we can ask her if she can approve us to take the consent from her husband or her father or her mother. If she approved because she is not concentrating from the pain, we can get the consent from the one that she said to get the consent.
Yeah, this is the last question, and sorry for the increasing question for you, Dr. Mohammed. This is the last question from our colleague, also Mohammed Suleiman. We need your advice and your to clear our how can we solve this problem. Dr. Mohammed asking in Anesthesia Clinic, when we have a very big number of patients, there is not enough time to discuss and the small details. What you suggest to overcome this problem?
In that case, we may prepare ourselves because before we can have printouts, brochures, or some papers that we give it to the patient. We can advise, as I said, some websites for the patient to know about the procedure. And then we can get the consent after that on admission of the patient before the surgery. After the patient read about the disease, about the method of therapy, about the risks and benefits of each method, we can make another interview with the patient and to get the consent. Also, it is better to get the consent, not to get the consent immediately before surgery. But if this is the situation, it may help to step the consent into.
At the end, just I want to declare something, because I just said Mega Academy and the name is changed, and Dr. Saad informed me. I just wanted to declare now it's Mega Medical Association, because if you wanted to search through the internet, it will be easy for you, because Mega Academy is changed now. And we need last word from Dr. Mohammed about the consent. What's your advice for us and for junior colleague about last word, a small word about the consent?
Dr. Yasser, if you don't mind, Dr. Adil Ibrahim has a question, if you don't mind.
Yeah, yes,
Dr. Mohammed.
Yeah. Thank you, Dr. Mohammed. Dr. Saad, الثلاثة اللي بدر صممناها على التمريض. Really wonderful lectures tonight. I have a question, but answered in the middle. I have a comment we are doing here. If unconscious patient or semi-conscious patient is going for surgery, usually we take a consent from two consultants. So to be usually the anesthetist and the surgeon to be to protect everybody, and because if you go without any consent, I think here is not acceptable in Europe. So we go with this way.
I mean without consent from the patient or his relatives. But most of the hospitals put this regulation. If you will go for life-saving surgery and the patient is not conscious, two consultants will sign that this procedure is needed for life saving for that patient. They sign that the procedure is needed to save the life of the patient as a documentation in the medical record.
If you don't mind, Prof. Nabil Asqalani is here, and he gave us fascinating lecture before about medical negligence, and might be related to the consent. And kindly, if he can have any comment to help us.
Yeah, Dr. Fahd, thank you very much for offering me this opportunity. As a matter of fact, there is no consent universal or guidelines for consent. For instance, each organization or each hospital has got its own consent, and this doesn't make sense. For instance, once for tonsillectomy, for instance, we used to let the father sign, I accept doing tonsillectomy operation and I accept the risks of surgery and anesthesia. The father said that I'm signing in this way the death certificate of my son. So it doesn't make sense. We've got several types of surgery, major surgery, intermediate surgery, minor surgery. Why shouldn't we have a uniform consent for all organizations or all hospitals, whether university or military or whatever the condition is? So it should be in a proper way, written, typed in a proper way, that all patients would accept it without any problems. Let's make this a recommendation for this, the mega medical.
I may have a little comment to myself here, because when I moved to Ireland, my culture was very, somebody asked about the culture, and it was very difficult to tell a patient that this surgery or anesthesia is very high risk and you may die during that procedure. I was really very shocked when I heard some of my colleagues tell the patient you will die. But now it's very easy to tell the patient accepting that. The patient wants everything to be clear, crystalline clear about the risk and the benefit, and if he is going to face any difficult situation. And the other thing is too funny. There is a solicitor outside the hospital, and he putting a signpost in the office that this office is for medical negligence. You know, just outside the hospital.
Yeah.
Okay, Dr. Mohammed, just for you and Dr. Assam to conclude.
Yeah.
I'd like to thank all the attendees, and I'd like to thank all the eminent speakers. And also I'd like to thank our great professors today, Prof. Nabil Asqalani, for his attending. And it is great honor for us to host such people, such expert people like Prof. Talat Al-Halim and Dr. Mohamed Ahmed. And I hope next lectures and next meetings to host people. And I think all the people in the medical association, they are great. And on top of them, Professor Saad Mahdi is our leader in this webinar. So thank you for all the attendees.
Thank you very much, Dr. Yasser.
I
think we have a comment from Dr. Khalda Radwan. Just 1 second, because she wants to talk. Dr. Khalda, Prof.
Excuse me, Dr. Saad, if you please, excuse me. I think we can't do a universal consent for all operations and all procedures. But the consent is also always indicated for any invasive procedures, even if it is not a surgical procedure or anesthetic procedure. If the patient is doing ERCP or doing EUS or any invasive procedures, we have to take a consent from the patient. Even interventional radiology, you have to take a written consent, informed consent for a patient, including the procedures itself and its complications. Its complications and its drawbacks, we must be informed to the patient according to the procedure which is doing. According to the type of anesthesia it's giving. If he have to approve, if he have general anesthesia or spinal anesthesia, and I told him everything about the procedures and the anesthetics to be given. And he approved all that according to the procedure and the type of the anesthetic to be given. So we cannot stabilize a general consent for the all procedures and all techniques and all anesthesia given.
Okay. Thank you very much. Dr. Mohammed, just last word before closing.
Yeah, my advice is that we have to give the informed consent the importance and care, and we have to discuss with the patient, especially if in high-risk patients. If we are doing a lot of surgeries that are not high risk in patients who is ASA1 or ASA2, we are not expecting too much complications or bad outcomes. We can go through rapidly, but in high-risk patients with a lot of comorbidities, we have to concentrate with him and we have to explain to him the possibility of ICU admission, the possibility of mechanical ventilation, the possibility of grave complications in a manner that does not make him to refuse the surgery. We have to show sympathy. We have to explain to him the importance and the benefits of surgery, and at the same time, we have to deliver the message that there are some bad outcomes that may happen, and the possibility of treating this and managing these bad outcomes in our facility. So we have to balance. We don't have to scare the patient more than needed, and we don't have to let the patient to feel that he is very safe and nothing will happen. This is not accepted in the informed consent process.
Thank you, Dr. Saad. Thank you for our professor. Thank you for our colleague, Dr. Prof. Assam, and for the speaker. I really enjoyed today, and I'm very happy to be with you. Even a listener, all the time I'm happy to be a listener, but to put me in this position, it's a great honor, and thank you.